it's Sarah here from BJC Health, coming to you from Sydney, Australia. Thanks for showing an interest in one of our educational events. You're about to watch part one, so enjoy the event. If you've got any questions about the content, then please consider joining BJC Connect, where you can access all of our facilitators live. Otherwise, please consider leaving a comment and we'll do our best to get back to you.
So we've been gifted a very interesting topic, and hopefully, we can shed some light on shoulders and elbows. So we thought we'd start with some funky facts just to lighten the mood, since apparently elbows are funky. So I put a few pictures in, and apparently the crab, is just like our shoulder joint. So I'm not sure if any of you will be able to pick the similarities, but the shoulder is the most mobile joint, having 10 different movements, and just like our friend the crab, who has 10 different legs. Some of you may know this already, but the length of from your elbow to your wrist is actually the same as your foot. So if any of you are more brave that are watching tonight, you're welcome to measure your own foot on the length of your forearm. The funny bone, and those of you who have knocked it before will probably know this, is actually not a funny bone. It's actually yourself hitting the ulnar nerve when you hit that. And this was my favorite funky fact when I was trying to Google some funny things to put in the presentation tonight. Apparently we can, some of us who are gifted can actually kiss our elbow. So apparently the Guinness Book of World Records gets at least 5 emails every day stating this fact, or people saying, oh, I can kiss my elbow, I should be in the record books. So in case you were interested, I actually tried, and I checked with Adam today as well, and he actually tried. And at this stage, both of us need to keep our day jobs, because both of us will not make the Guinness Book of World Records. All right, so moving on to some more serious stuff. I will go into some anatomy. Some of you may have attended some of the BJC Connect talks on the shoulder, so some of this may be revision for you guys. But the shoulder's often called or likened to a golf ball sitting on a tee. And that's because the ball of our arm joint, which is called the humerus, actually sits on a very little small spot connecting to our scapula, or our shoulder blade bone, called the acromion. So where it articulates or joins is actually a really, really small surface. So that's why, in particular for the shoulder joint, the muscles and the ligaments have a very crucial role in keeping its stability. So again, as Sarah said, some of this is quite complex, so I'll try and keep it simple, but please, if you have any questions, make sure you chuck it in the chat. So this diagram just illustrates some of the big muscles that you may be aware of around our shoulder joint. So the 3 bones that make up our shoulder joint, the first one's called the clavicle, so that's your collarbone. The second big bone that makes up our shoulder is called the scapula, or that bone at the back of your shoulder. And the third bone is called your humerus, so that's your arm bone. Okay, so the 3 of those bones make up your shoulder joint, and the 3 joints are called your acromioclavicular joint, or your AC joint. So that's the one at the top here. Some of you may hear of rugby players that dislocate their AC joint, so that's this guy up here when they get a big blow to the shoulder. You have your glenohumeral joint, and that's this one here. And then you have also your sternoclavicular joint. So that's through the middle near your sternum. Okay, so there's lots of muscles around the shoulder joint. There's actually 20. So it's a massive joint with lots of different muscles. And the main area that you guys may be aware of, and some of the big injuries you treat, are to your rotator cuff. Okay, so the rotator cuff is actually a group of muscles. There's 4 muscles that make up this group of muscles called the rotator cuff, and they're called your supraspinatus, your infraspinatus, your subscapularis, and also your teres minor. So one of the main movements that this group of muscles called your rotator cuff does is it does what we call external rotation of the shoulder. So in case you were wondering, and you can all do it with me, external rotation is when you have to put up your one of the types of external rotation is when you put up your arm just like this. So this would be some of my rotator cuff muscles working. Okay. One other thing I'd like to mention from this slide is there's something called the capsule in your shoulder, and this will come into play more when we talk about frozen shoulder later on in the presentation. There's obviously lots of other big muscles, such as ones called like your biceps, your triceps, your pec, and they all surround the shoulder joint as well. Okay, and then we get to the ligaments. So the ligaments hold the bones together. Again, there's lots and lots of ligaments. If some of your ligaments kind of get torn, you might have an injury such as like a dislocated shoulder. In this diagram, you'll also see and it's green in this diagram, and then there's a lot of different structures called your bursa. So often in some of the shoulder conditions that we may see in the clinic, you may hear of conditions such as bursitis. And what that is an inflammation of these fluid-filled sacs around the shoulder joint. Okay, and just a quick slide on the elbow as well. So again, there's lots of different muscles. The elbow, fortunately, isn't quite as complex as the shoulder. There's really two major muscle groups that we often like to refer to. And these are then related to conditions which you may have heard called tennis elbow and golfer's elbow. But pretty much you have one major group which extends the wrist or does this movement. So they attach to the funny bone or that bone on the outside. And then you have one major group of muscles on the inside of your forearm, and they're called your wrist flexors. And they connect to the inside of your elbow. And these two groups do most of the major movements around your forearm and your wrist area. Okay, I'm going to pass it on to Adam now, and he's going to go through a bit on inflammatory pain.
So hi, everyone. Before I go into this, I'm actually just going to talk a little bit first about something that I think might confuse some people, and that's about where you actually feel the pain when you have a problem in your shoulder or your elbow. And I always tell people the brain's not very good at localizing where pain's coming from. So if the problem's in your shoulder or in the rotator cuff that Belinda was just talking about, you can actually feel it anywhere from the neck down to the elbow. And so most people, when they come in with shoulder problems, actually feel pain in the upper part of their arm. So a lot of people think, oh, I've got a muscle problem, but actually it's coming from the shoulder. So where you're feeling the pain isn't necessarily where the problem is. And I just saw a question in the chat box about, can tight muscles trigger a headache? And they definitely can. So I think we're going to talk a little bit more about the role of muscles and fascia when they become tight and the types of pain that can cause. But certainly these muscles, I mean, I've got terrible posture. I always tell my patients I'm a massive hypocrite when I'm correcting people's posture. But if your posture's rolled forward, your head's poked up, then these muscles can get very tight and certainly can cause pain up into the head or down the arm. So when someone comes in to see me with pain, as a rheumatologist, I'm always trying to figure out if they've got what we call inflammatory pain or mechanical pain. And I just wanted to go through that now because I think it gives you a bit of a clue on who's going to be more helpful, i.e. either a doctor or a physio. Now, inflammatory pain, by that I mean autoimmune things. So conditions where the immune system has made a mistake and starts to attack the joints or tendons in the body. Now, classically, if it's following the textbook, which doesn't always happen, but if it's following the textbook, the pain in this setting tends to build up when you're still. So when you first wake up in the morning, things tend to be really bad. They're stiff and sore, and it takes at least half an hour to get going. Now, as we get older, we can all wake up, with a bit of stiffness in the morning or a bit of soreness in the morning, but it can get going pretty quickly. So, by the time you get downstairs or you've gone to the bathroom, it's gone away, and that can be normal. But if it's lasting for longer than half an hour, that's too long, and that fits into this category of inflammatory pain. Now, often inflammatory pain causes swelling. In a shoulder, we don't tend to see that because the shoulder joint itself is really deep, and so you don't actually visibly see this. It has to be pretty massive to see that. But in an elbow, you certainly can see it sometimes. You can get warmth around the joint, and sometimes I put erythema, so I shouldn't put that. Redness is what I mean by that. But to be honest, most of the time you don't tend to see that. Now, mechanical pain is different. That's got nothing to do with the immune system. That tends to be more related to the aging of the joints or the tendons, your posture, how you're using your muscles, how strong your muscles are. And generally this pain becomes worse the more you do. So you generally do stuff around an area that's under stress and you pay for it at the time or you pay for it afterwards. You might be a little bit stiff in the mornings, but it tends to resolve pretty quickly, like I was saying, less than 30 minutes, and you usually don't tend to get swelling. So if you have inflammatory pain, generally that's something you want to see a rheumatologist for. That's where I come in to try to help. So if we just hit the next slide button along there. And then if you've got mechanical pain, to be honest, the physio is going to be way more helpful for you, or more helpful for you most of the time compared to any doctor. But having said that, the next slide, often, we have a role for everybody here. So often the physio can help sometimes in inflammatory, and doctors can sometimes help in mechanical. But as a general rule, if you have more mechanical problems, physio is going to be more helpful. If it's sounding more inflammatory, a doctor is going to be more helpful. We'll go to the next slide. So in terms of inflammatory causes of shoulder pain, again, these are the things that a rheumatologist is going to treat. So by that, I mean inflammatory arthritis. So things like rheumatoid arthritis or psoriatic arthritis. These are conditions where the immune system, as I said, is attacking a joint. It's pretty rare for that just to attack one shoulder and that is it. It tends to involve other joints as well. Polymyalgia rheumatica is another type of autoimmune condition that happens in people over the age of 50, not under the age of 50. And it's where the immune system's not attacking the joint, but actually the soft tissue around the neck, the shoulders, and the hips and buttocks. And so it's not going to be just one shoulder, one hip. It's always symmetrical. So it's both shoulders, both hips, the neck. Pseudo-gout is a condition that behaves like gout. And it's basically due to a calcification in joints that can trigger acute inflammation in the joint. And that can just come out of the blue. So the people that get this all of a sudden just wake up for no rhyme or reason, have significant pain in their shoulder, can't move it. It's really agony. Sometimes they treat it, sometimes they don't. But in any case, it'll go away on its own. And generally within a week or two, it's gone, you're back to normal, thinking, what on earth just happened? And that's what happens with pseudo-gout. So if you're getting any of those sort of symptoms, you definitely need to be seeing your GP and considering to see a rheumatologist, because in these conditions, unfortunately, medication is really the only way to treat it. Now on the next slide, then we've got elbow pain. So elbow pain, similar thing. So inflammatory arthritis, rheumatoid arthritis, psoriatic arthritis can affect the elbow. But again, like I said before, it doesn't tend to happen just in one joint. It tends to happen in multiple joints at a time. Now, pseudo-gout can affect the elbow too, but so can gout, which behaves exactly like pseudo-gout, just bang out the blue, causes significant inflammation. But for whatever reason, gout doesn't tend to affect the elbows very much. We don't really understand that. And again, in these conditions, you need to see your GP or a rheumatologist. And I've just seen a question coming up saying, why is there a cutoff of 50-year-olds for polymyalgia rheumatica? Is it purely arbitrary or is there a biologic basis? Look, again, we don't really understand why not. There's so many things that happen in the body that we don't really understand. I always thought when I became a doctor, I was just going to know everything. And the more I've learned, the more I realize, wow, we don't know a lot. And we don't know why it only happens. It's a bit arbitrary why it only happens in over 50-year-olds, but it does. So we'll move to the next slide. So these are mechanical causes of pain. And again, these conditions tend to happen relating to either injury, the general aging of the joint, if your muscles aren't strong enough around the joint, so then the tendon's under pressure or the bursa's under pressure and become inflamed. Myofascial, now that's the fancy medical word for meaning if your muscles are getting tight because your posture's not great. And also a condition called frozen shoulder, which we're going to talk about in a little bit. We'll go to the next slide. And so when do you need a scan? So obviously this is something a lot of people think, it makes sense, right? You have pain, you think, well, I need a scan to know what's going on. But actually it's not as helpful as you'd think, in particular with shoulder problems. So the reason for that, and Belinda's got a slide on that coming up next, but as we get older, a lot of us get tears, for instance, in our tendons, and the supraspinatus tendon, which helps lift your arm up like this. I've got a tear in mine. So I was a model. Sorry, that sounds wrong. I was a dummy person for an ultrasound course, so they were ultrasounding my shoulder for people. And yeah, showed up a tear. I had no idea. And my shoulder moves fine. I don't have pain. So you can see things on scan that aren't necessarily causing pain or problems. So that's one potential problem with a scan. The only time I really do a scan, if the diagnosis is really unclear, we just really have no idea, or we're thinking between a few things, then I'll consider doing a scan. If I'm worried someone has a tear, and by that I mean acutely, so if someone's had an injury and they suddenly can't lift their arm, or it's really grabbing or locking, I might consider a tear, and then a scan might be helpful because in an acute setting, you might be thinking about surgery. But tears, as I said, can happen over a chronic period, more related to age. And it's amazing in that setting how the body compensates. As I said, I've got a tear, but you wouldn't know it with me moving my shoulder because my body's compensated for that. And so if it's a chronic setting, I'm not so worried about it. And then, of course, if patients aren't improving with physio and not behaving, the way I expect things to go, well, then I might organise a scan in that setting too. Like I said, scans aren't perfect. They will show things we aren't expecting sometimes. So that ties into what Belinda can talk about next.
All right, awesome. So this is kind of just to summarize what Adam just went through with us in terms of, I guess, investigations may be coming back positive for a lot of things. Before I go into this, something I thought I'd also like to add in terms from a physio front, often you will find things of investigations, but it actually often doesn't change your management. So which rotator cuff muscle you might have an injury or, for example, if there's arthritis in joint, we know typically we have to look and check certain different things and make sure there's strength and stability around certain joints. So regardless of what the structure that isn't, that comes up positive to showing something that isn't 100% on the scan, it may not change your exact management. But some of you that attend our Connect Talks regularly, you've probably seen our friend the skeleton. So in terms of the shoulder, and we use this diagram a lot for lower backs, but it's quite similar to the lower back ones you may have seen in that in a study where they looked at 51 men aged between 40 and 70, 22% of participants had what we call a partial rotator cuff tear, and 78% of people actually had bursal thickening. I'm not sure if these people were symptomatic or asymptomatic, but I guess my guess would be that a fair number of these people may be asymptomatic. They wouldn't have pain or, be showing any significant dysfunction. And 96% of people, so that's pretty much everyone above 40, showed some sort of abnormality, okay? But these days with the patient group I tend to see in the clinic, I more or less tell people, if you're above the age of, say, 40 or 50 and you don't have anything wrong with you at all, that is almost more unusual because, again, as Adam and I have both alluded to, most people will have something that isn't quite perfect on a scan, and that is totally okay. Okay, so Adam will talk a bit more about the rheumatological management of some of these patients that we see with shoulder pain. But I thought I'd get into what physio can offer. So as we kind of said earlier, the two do work together quite well at times, and we'll go into that more. But in terms of the physio and the specifics that your physiotherapist might be working with you on, the first will be the first important part of your treatment may be around pain relief. So we know that if you've had pain in any area of the body, but definitely pain in the shoulder, you might start moving abnormally. So you might start hitching your shoulder, you might start moving in unusual planes of movement just to avoid pain. And that is a very normal thing. But what then happens, and again, over time, this may increase, is that you then get muscle tightness perhaps in certain spots. You might also get weakness, which will need strengthening, but definitely the muscle tightness or weakness can cause more pain. So often the first step that we like to do is try and reduce the patient's pain. So this massage is one way. Other ways that your therapist may do with me, it might be stuff like dry needling, which some of you may experience before. But the quicker we can reduce your pain, hopefully what that means is the quicker you can return to some sort of normal function. And this is especially important if you've had pain for, a number of months. One other way we reduce pain is by taping often. So kinesio tape, which is that colored tape you see in that middle picture, is often a really good way to encourage normal movement in a shoulder joint again. It's very, very comfortable, often can last on patients for a period of time. The girl against the wall, you'll see she's using a massage ball. So often we might get patients to use a massage ball to massage certain tight muscles around their neck, around their shoulder, maybe even their upper back. Something I haven't mentioned yet is obviously, with any sort of shoulder rehab, there's going to be a fairly big focus on your shoulder muscles. So some of those muscles we spoke about in the initial pictures with the anatomy. But also what's really important for your therapist is to actually look at your neck and also your upper back as well. So if your neck isn't moving well, or if your upper back isn't moving well, it's going to immediately put a lot more stress onto your shoulder joint. And it can also be a bit of chicken and egg. So if you've had shoulder pain for a while, you might start using your neck muscles more or your upper back muscles more. Something some of you may have seen in some of these previous talks, and also why we like to focus on posture in the upper back a lot, is that if you, and I'll just reposition my screen. So if you sit in a really slouched position and you try and lift up your arms, it's actually really, really difficult. So I feel very limited. If I straighten up my back and try and lift again, it feels so much easier. So that's one reason why your physio may think it's really important to focus on your posture. So the picture with the girl on the left in the pink t-shirt, you'll see she's wearing a funny contraption around her shoulders. So that's actually a posture brace. Again, for the reasons I just explained, we really like to focus on posture. So things like braces can help to reduce a person's pain. During the COVID pandemic, and with a lot of our patients working from home, what we've seen a lot with our patients in the clinic is a lot of our patients really aren't moving enough. And what that means is they're often stuck in quite sedentary positions for a long period of time. And then what that means is then often that might involve slouching in front of a laptop, maybe using a bit too many devices such as your phone. And then this also encourages not so adequate posture. So just talking about movement and getting moving more over a period of time can also help with things like your shoulder pain. Back to more specific kind of shoulder rehab. Some of you may be familiar with kind of band exercises that many of the physios like to start on. This can be very important to get the right muscle groups working. Again, if you've had pain for a period of time, a lot of these muscles will tend to switch off or not work as well, or they might get a bit weaker. So starting with band work can be a very good way to get these muscles working. And it's also very easy to do because most people can get a band and do it from home. There's no need to join a gym. Eventually, and doing a push-up if you have shoulder pain can feel very daunting, I understand. But eventually, the aim might be to move to some of the bigger muscle groups as well. So you might be doing exercises such as push-ups. Things like push-ups is a great example because actually every day, most of us will push a lot of things. So you might push a trolley, you might push a door. They're just some examples. You might have to pull your car boot down. So it's really important to also do some of these bigger muscle movements when we're looking at shoulder rehab. And as I said, the stretches for your neck are also important too. So when it comes to shoulder rehab, if your pain's starting to settle down and you're doing a bit better, you've got all your movement back, we also like to look at how the whole body's moving. This may be with your physio, it may be with a personal trainer or an exercise physiologist, but it's really important that you actually look at your strength of your whole body. Okay, I use most of us will not throw a ball as well as this New York-based baller, but it's important to kind of understand a little bit about why we might look at the whole body. So if we think about a throw, most of us will first of all consider that you need a strong shoulder, and that's very obvious. We need to be able to throw the ball as far as we can. But if we actually look at the biomechanics or how our body actually has to move to throw, you actually have to do a fair bit of, let's say, body rotation or torso rotation. Your hips also need to rotate. You might need to plant your foot down quite hard, and all these little things will actually help to make your throw a bit stronger. The more things in that whole, line of mechanics that works well, the less your shoulder actually has to work. So I went to a talk by an orthopedic surgeon a long time ago, and he actually said that in baseballers, the ones that didn't have good core strength, they were more likely to have elbow troubles or need elbow surgery later on in their career. So of course, definitely it's important to look around the shoulder and look at your rotator cuff muscles. But if we're going to do really, really adequate rehab and we want to make sure the shoulder doesn't continue to worsen or come back to bother you later on the track, we actually want to look at the whole body as well and start to train some of those bigger body movements.
So you've just finished watching part one of our recent educational events. Hope you enjoyed the content. If you'd like to access part two, then you need to sign up for BJC Connect. It's a free platform where you can access not just the recordings of past events, but also access a whole range of upcoming future events live. All of the details that you need to join VJC Connect are now flashing up on your screen. But otherwise, like our staff, subscribe if you'd like to see more information from VJC Health. Look forward to seeing you in an event soon.